Hello and welcome to the online endocrinology lecture. This lecture will be one of 3 separate lectures emphasizing endocrine diseases. The objectives of this lecture are as follows. Develop an understanding of the basic underlying concept of endocrine disease. Identify the hormones released by the anterior and posterior pituitary. Differentiate the syndrome of inappropriate antidiuretic hormone and diabetes insipidus. Differentiate hyper and hypoparathyroidism, and apply management principles to the aforementioned conditions. In all of the endocrine conditions, the basic underlying problem is either an excess or a lack of a particular hormone. An understanding of the underlying mechanism of action of each hormone is essential in understanding endocrine disease. The pituitary gland is often referred to as the master gland. It rests in the sella turcica of the sphenoid bone and is an extension of the hypothalamus. The anterior pituitary is responsible for releasing follicle-stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, thyroid-stimulating hormone, prolactin, and growth hormone. A good way to remember this is through the mnemonic flat pig. The posterior pituitary releases antidiuretic hormone and oxytocin. Let's take a closer look at antidiuretic hormone. The release of antidiuretic hormone, or vasopressin, is stimulated by hyperosmolarity, decreased atrial receptor firing, angiotensin II, or sympathetic stimulation. Vasopressin then targets either V1 receptors in the blood vessels, resulting in vasoconstriction and increased systemic vascular resistance, or V2 receptors in the kidneys, resulting in increased fluid reabsorption and increased blood volume. Both of these together result in increased atrial pressure. The first condition associated with antidiuretic hormone is the syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH is characterized by inappropriate or excessive release of antidiuretic hormone, which occurs independent of osmolality or fluid-dependent stimulation. This results in inappropriate water retention. There are a variety of causes, including tumors producing antidiuretic hormone, skull fracture or head trauma, central nervous system disease or infection, lung disease such as bronchogenic carcinoma, pneumonia or pneumothorax, and medications such as vincristine, tricyclic antidepressants, thiazide diuretics, and nicotine. The manifestations of SIADH include neurologic symptoms, primarily due to hyponatremia, which includes mild headache, seizure, and coma, as well as decreased deep tendon reflexes. The patient may also develop hypothermia, weight gain and edema, as well as nausea and vomiting. In terms of diagnosis, the patient has a euvolemic hyponatremia with a sodium less than 135 milliequivalents per liter. The serum osmolality will be low, indicating dilution, and this is because of the retention of water. On the other hand, the patient's urine osmolality, urine sodium, and specific gravity are often high, indicating concentration of the urine. In terms of management of SIADH, it's important to identify and treat the underlying cause. Intake and output, daily weights, and serial sodium are all important components of SIADH management. If the sodium is greater than 120, fluids are often restricted to 1,000 milliliters per day, and the patient's monitored. If the sodium is between 110 and 120, and the patient is without neurological symptoms, fluids are restricted to 500 milliliters per day, and the patient's monitored. If the sodium drops below 110, or the patient develops neurological symptoms, then the patient is usually initiated on isotonic or hypertonic saline. A furosemide drip may also be considered. The next condition associated with antidiuretic hormone is diabetes insipidus. Diabetes insipidus is characterized by a low antidiuretic hormone due to several causes. There are 3 broad categories of causes. Central DI is related to either a pituitary or hypothalamus lesion. This can be idiopathic or associated with trauma, such as with a head, hypothalamus, or pituitary lesion, surgery, infection, such as with TB, meningitis, or encephalitis, tumor, or metastasis. Nephrogenic DI is due to a defect in the renal tubules. This can be either congenital or acquired due to pyelonephritis, potassium depletion, sickle cell disease, chronic hypercalcemia, and medications such as lithium, methicillin, dimeclocycline, and alcohol. Finally, psychogenic DI occurs from compulsive water drinking. The manifestations of diabetes insipidus includes the following: thirst or cravings for water, with an intake often between 5 and 20 liters per day; polyuria, with greater than 250 milliliters per hour output; and nocturia; weight loss, fatigue, altered mental status, dizziness, hyperthermia, tachycardia, hypotension, and poor turgor or xerostomia. In terms of diagnosis of diabetes insipidus, these patients will be hypernatremic, have an elevated BUN and creatinine. The serum osmolality will be high, indicating concentration, and the urine osmolality as well as specific gravity will be low, indicating dilution. A simple test for the diagnosis of diabetes insipidus is the Miller-Moses test. This is also referred to as the water deprivation test, where the patient is maintained NPO for 8 to 12 hours, and there is a resulting 3 to 5% weight loss. This confirms diabetes insipidus. Another test that can be done is the Vasopressin challenge test. The patient is given 0.05 to 0.1 milliliters of intranasal desmopressin or 1 microgram subcutaneously or IV. The patient's urine volume is then measured, and in the case of central diabetes insipidus, there's a high urinary output, whereas in nephrogenic diabetes insipidus, the urine volume doesn't really change. If there's no apparent cause, an MRI is often done to look for a mass or a lesion. In terms of management of diabetes insipidus, if the sodium is greater than 150, the patient's given D5W IV to replace half of the volume deficit in 12 to 24 hours. It's important to note that rapid lowering of the sodium can result in cerebral edema or pontine demyelination. So in this case, keep an eye on serial sodiums and avoid greater than a 0.5 milliequivalent per liter per hour increase in the sodium. If the sodium is less than 150, the patient can be substituted with half or 0.9% normal saline. DDAVP or desmopressin can be given in an acute situation. However, it should be used cautiously if there's a history of coronary artery disease because it produces vasoconstriction. Adequate hydration is another key element in diabetes insipidus management. In the case of nephrogenic DI, the clinician may consider thiazide diuretics, salt depletion, and prostaglandin inhibitors such as an NSAID. To summarize, in diabetes insipidus, the patient's high and dry. So there's high urination, hypernatremia, the serum osmolality is high, and the urine is very dilute with a low urine osmolality and urine-specific gravity. The patient's dehydrated and experiences weight loss and excessive thirst. In SIADH, the patient's low and wet. There's low urination, hyponatremia, the serum osmolality is low, indicating dilution of the system, and the urine-specific gravity as well as urine osmolality are high, indicating concentration of the urine. The patient experiences fluid retention, weight gain, and hypertension. Now let's take a look at the parathyroid. The parathyroid glands are attached to the thyroids as shown as brown bean-shaped structures in this image. The parathyroid primarily functions in calcium homeostasis. A low serum calcium stimulates the parathyroid glands to release parathyroid hormone. This produces demineralization of the bone and an increase in the plasma calcium level. On the other hand, when there's an increase in plasma calcium, there's stimulation of the thyroid C cells, which release calcitonin, which increases osteoblastic activity and shifts calcium into the bone, resulting in a decrease in calcium. Let's first take a look at hyperparathyroidism. In this condition, there's excessive parathyroid hormone, resulting in hypercalcemia due to bone demineralization and hypophosphatemia. The etiology can be broken down into primary, secondary, and tertiary causes. Primary hyperparathyroidism is associated with an adenoma. Secondary hyperparathyroidism is associated with chronic kidney disease due to poor phosphorus retention or vitamin D deficiency. Tertiary hyperparathyroidism is associated with hyperplasia or is idiopathic. The manifestations are often associated with hypercalcemia. In general, the patient may experience fatigue and volume depletion. Cardiovascular manifestations include hypertension, bradycardia, a decrease in the QT interval, and left ventricular hypertrophy. Musculoskeletal manifestations include muscle weakness, deformity, fractures, and joint abnormalities. Gastrointestinal manifestations include nausea and vomiting and abdominal pain. Neurological and psychiatric manifestations include altered mental status, coma, and psychosis. And genitourinary manifestations include nephrolithiasis. The patient with hyperparathyroidism will have hypercalcemia and hypophosphatemia, as well as an increase in parathyroid hormone. The patient may also have decreased vitamin D levels. Ultrasound, MRI, or fine needle aspiration of the parathyroid may be done to identify the pathology. Complications of hyperparathyroidism include osteopenia or osteoporosis, pancreatitis, and nephrolithiasis. Management includes surgical excision of the parathyroid, and the indications include less than 50 years of age, questionable adherence to outpatient follow-up, a calcium level greater than 1 milligram per deciliter above the normal limit, a urine calcium of greater than 400 milligrams per deciliter, a greater than 30% reduction in renal function, nephrocalcinosis, osteoporosis, or severe psychiatric disease. These patients are also given fluids. It's important to encourage PO intake of greater than 2 liters per day to prevent dehydration and nephrolithiasis. IV fluids, particularly sodium chloride and a loop diuretic, can be used to increase calcium excretion. Calcitonin may be administered to oppose parathyroid hormone. The patient may also receive IV bisphosphonates or PO phosphates. It's important to avoid thiazides and excessive calcium in diet or medications, such as with Tums. Finally, encourage mobility to increase osteoblastic activity. The last condition we'll discuss is hypoparathyroidism. This condition is characterized by low parathyroid hormone, resulting in decreased GI absorption and renal reabsorption of calcium, producing hypocalcemia and hyperphosphatemia. The etiology of hypoparathyroidism includes the following. It can be iatrogenic, associated with thyroidectomy, which is the most common cause, Ham syndrome, which is an autoimmune condition in a child. It can be congenital, associated with hemochromatosis or thalassemia, associated with Wilson's disease, hypermagnesemia, or vitamin D deficiency. The manifestations are primarily due to hypocalcemia and can include paresthesias, hyperirritability, fatigue, anorexia, mood disturbance, seizures, hoarseness, wheezing, and dyspnea, muscle cramping, diaphoresis, hypomagnesemia, hypokalemia, and alkalosis due to hyperventilation. The physical examination may reveal Schwesteg's sign or Trousseau's sign. In this image, A shows Schwesteg's sign and B shows Trousseau's sign. In terms of diagnosis, the patient will have hypocalcemia as well as hyperphosphatemia, a low parathyroid hormone, alterations in the vitamin D level, and the X-ray may show increased bone density and calcification. In terms of management, the patient should receive IV or PO calcium with a goal of 9 to 10 milligrams per deciliter. This can be done through diet or through calcium gluconate, either IV or PO. The patient can also be given aluminum hydroxide or aluminum carbonate to bind phosphorus and decrease phosphorus levels. These patients may also receive vitamin D2 or D3. Some patients may be given recombinant human parathyroid hormone. Finally, thiazide diuretics may decrease calcium excretion.